to the demo.
This is really good.
46-year-old male who has a combined aortic valve disease, regurgitation, and stenosis. He undergoes aortic valve and descending aorta replacement, and he is found unconscious at home. He's brought to the clinic after 3 months of the operation, and CT showed a large hemorrhagic stroke. He had to undergo trepanation. His CRP was really high, and we performed an echo. This was the cause of the stroke, and I guess you can understand something is wrong with the prosthesis in the aortic position.
Yes, that's completely correct. If you put all of this information together, the patient has an endocarditis of the prosthetic valve. You see a structure here, which we call vegetation, a mobile structure, and part of it has probably dislodged and caused the stroke. You would see not only this, but also that there is a lot of echoes around the prosthesis. What we have here is an abscess. So a massive form of endocarditis, and with the sequence of a stroke, showing you how dramatic endocarditis can be.
Yes, we performed also a transesophageal study on him, and you can really see this absence in the cross-section in the long axis, respectively on the right and the left. And you see this vegetation going into the left ventricular outflow tract coming from pseudoaneurysm, what we call.
This shows that the TE study provides additional information. We see that there's partial detachment of the prosthesis here. Now remember, this is a combined aortic root replacement with a valve. So this is actually the tube of the aorta here that you see, and this is the prosthesis, which is kind of detached here. So a very severe form of endocarditis.
And this chapter deals with infection of the heart. Not only endocarditis, but also myocarditis and pericarditis. So we will start with the endocarditis. What is it? Well, it's an endovascular microbial infection of cardiovascular structures. This means it can involve the valves, but also ventricular and atrial endocardium, as well as large vessels and especially prosthetic material. It means the prosthetic heart valves and the polymer-associated structures, so the line. When do you suspect endocarditis? Well, first, look at signs and symptoms of infection. So fever, of course, but also night sweats. You could also have signs of complications, as the example we showed you, or heart failure, or the appearance of a new murmur in the context of fever. Consider that there are predisposing factors to endocarditis. This could be mechanical factor like congenital heart disease, catheters, or trauma, toxic factors, for instance, in drug abusers, and immunologic factors. And of course, if you have blood culture which is positive for the typical agents of infection of the heart, and I'm talking about Staphylococcus aureus, or epidermidis, or Streptococcus bovis, or Enterococcus, the suspicion gets higher. Echo can help you. When you find a positive echo for infective endocarditis, the diagnosis is really almost done. What can you find? Well, vegetation, abscess, as we showed you, or new partial distensions of prosthetic valve. So in which lesions do you have a higher probability of developing an endocarditis? Well, apart from prosthetic valves, it's stenotic lesions, bicuspid valves, or a mitral valve prolapse. So for you to remember, every kind of lesion where you have high velocity jets. But to make the diagnosis, and this is also what the guidelines say, remember, combine all the factors that you have. So echo findings together with blood cultures and clinics. Depending on these factors, you can define the diagnosis as definitive or probable and possible. But remember, the most important thing is, even when you do not find endocarditis, follow your patient up, because then you could discover it later.
Here's some typical images of patients who have endocarditis. If you look at these images, you see how massive infection can be. For example, here you have a mitral valve which is affected. This would be aortic valve. You have little lesions all over the cusps, multiple lesions, which can lead to all sorts of pathologies. So this is something that the surgeons do not like very much because it's very difficult to sometimes operate into an infection. And the more massive the infection is, the more difficult it is to repair the valves. Now let's take a look at some echo images to show you what we see. The hallmark, as Anna already mentioned, is the vegetation. It is basically kind of a mixture of blood and infectious material which is attached to the cusps, here in this case of an aortic valve, and which have kind of a flotating motion within the blood flow and are more or less mobile. If you see this, the likelihood is very high, especially if you have, as Anna mentioned, clinical signs of infection, that it is endocarditis. Here is another example, this time on the mitral valve. You see, transthoracic echo is a good way of detecting endocarditis in many, many patients. And here is an example of endocarditis on the tricuspid valve, a massive vegetation here, and probably part of the tricuspid leaflet is disintegrated and the valve is certainly incompetent. A patient, of course, who had drug abuse. You sometimes also see vegetations on the pulmonary valve, which is actually a rare finding, but this image just documents that you can find vegetations on so many different structures in the heart. Also on pacemaker leads. This is a pacemaker here, and if you look closely, there's a vegetation right here. This is actually one of the main problems we are confronted with now. Many patients now have pacemaker leads, and they are at increased risk of vegetations, and something that certainly is a life-threatening disease as well. What do you think is the problem here? Take a look. Well, you will probably remember left ventricle function is okay, but the right ventricle is dilated. The patient has a very high heart rate, and focus again on the tricuspid valve. Anna, what is it?
Well, I remember perfectly this patient. This is another example of drug abuse, and again, the tricuspid valve is involved with a vegetation.
Right. This is a tricuspid valve endocarditis, and if you have kind of the combination of a patient who has drug abuse plus fever and maybe even pulmonary abscesses, then the diagnosis is almost certain endocarditis. And with echo, you then only have to confirm the diagnosis. So here is the vegetation on the tricuspid valve. And this is an example of a very poor patient. She was immune compromised, a lung transplant patient, and she developed mitral valve endocarditis with this huge, massive vegetation here on the leaflets, infiltrating the ring. The reason for this was fungal infection. Fungal infection is something that is, of course, more common in patients who are immune compromised and sometimes can create such large vegetations. I think in this case, the diagnosis is very easy to make, especially again if you have the signs of infection. And here's another example of a patient with tricuspid valve endocarditis. Look how large the vegetation is here. And again, the valve is probably destructed, causing severe regurgitation. This is a general finding in endocarditis because endocarditis kind of disintegrates the valves, destructs valve tissue, and therefore leads to incompetence. Sometimes also stenosis, especially in prosthetic valves, but mainly the problem is incompetence.
Endocarditis can cause complications, and the diagnosis of endocarditis could be done on the finding of vegetation or directly on the finding of complications of endocarditis. What do I mean? Well, you could not find a vegetation, but for instance, you could find a perforated leaflet, like in this case, where there's a real hole in the mitral valve causing regurgitation. Or you could find massive regurgitation. In this case, it's involving the aortic valve, and the valve, as you can see, is completely disrupted, the cusps are ruptured, and this is exactly where the regurgitant jet comes from. So you see there are 3 vegetation, and the valve is not recognizable anymore. Another complication can be obstruction. And look at this case to understand. Here we have a prosthesis in tricuspid position. This is a patient who is a drug abuser, and she received a prosthetic valve for endocarditis, and when we saw her again, because she had fever, we found endocarditis again, causing stenosis. Another complication is abscess, as we showed you in our example, and here the infectious material is all around the aortic valve, so involving the fibrous tissue, and on the right loop you can see it's invading also the myocardium. So extremely difficult to operate on these patients, and extremely high is the risk of dying. Another complication is a pseudoaneurysm, maybe more difficult to diagnose. You have at this point to know that it exists. We're showing you examples because when you see these complications once, you will never forget. And here, for instance, it's a pseudoaneurysm.
But not everything that looks like endocarditis is really endocarditis. Here are 4 examples. Do you think any of these patients has endocarditis? Take a look at this structure here. Does the valve here look normal? What about this here and this here? And do you see anything around here? Here is the solution. In this case, what we have is annular calcification right here. This is not an endocarditis, even though these patients are at risk of developing endocarditis. And right here, we have what we call endocarditis Liebman-Sachs in a patient who had lupus, SLE. So not really infectious form of endocarditis. And right here, those structures I mentioned are not a vegetation, but they're actually a tumor. And it is not a patient at all, it's a dog. This is a veterinary study. So you see even dogs can have cardiac pathologies. And on the right-hand side, this is simply a homograft. And this is just the echo after surgery. We see the homograft being implanted, and this is just a little bit of thickened tissue, but certainly not infective. So as you see, echocardiography can sometimes be misleading, and what Anna said is completely true. You have to sometimes put into the clinical context and to look at whether or not signs of infection are present. Okay, we have one last question to answer. What is the role of transesophageal echocardiography? Now, in the cases we've shown you so far, we interspersed a few TE images already. Well, the role of TE, I think, is quite clear. While transthoracic echocardiography has a fairly high diagnostic yield, it's even higher with TE. And especially if you have small vegetations or complications of endocarditis, then TE probably has the edge. And at least in our institution, we perform a TE in every patient where we already made the diagnosis with a transthoracic echo, because we usually can get additional information, as we saw in the very first case that Anna presented. So this example demonstrates this very nicely. This is a case that we actually weren't able to diagnose from a transthoracic echo, and with transesophageal echo we could nicely see the vegetation right here. We will have a chapter on transesophageal echocardiography, and we're going to show a number of cases there as well. But for you to remember, if you have a suspicion of endocarditis from a clinical perspective or because of the echo, always go to a TE.
And are you ready for a new case? Here it is. 35 years old male. He has flu, palpitations, and tachycardia. He's actually a colleague of ours, and he's on call. He asks the colleagues to write an ECG, and here is the findings. We have a slight ST elevation in the lateral, inferior, posterior leads. So can it be a myocardial infarction, posterolateral or inferior maybe? Of course, we sent him immediately to the cath lab, but the coronaries were completely normal.
We did establish the diagnosis of a viral myocarditis, and the patient fortunately recovered function was normal. He did not have any sequels or problems. But the key message here is that, of course, myocarditis can sometimes look very similar to coronary artery disease or an acute myocardial infarction. So what should we be looking for on the echocardiogram? Well, some patients present with global dysfunction. Sometimes we only see regional wall motion abnormalities, as in the case that Anna just presented. Sometimes we see pericardial effusion, and in some patients we see this. This is the same patient on the left-hand side during the acute phase of viral myocarditis. Look at the thickness of the myocardium here and compare it with the same patient 3 weeks later. LVH is practically gone. What we have here is myocardial edema, which vanished after infection was gone. Function is also better after 3 weeks. So what we find on the echocardiogram can vary greatly depending on the clinical presentation of myocarditis. Some patients have such massive left ventricular dysfunction that they might even need acute heart transplantation or left ventricular assist devices. Other patients have very, very subtle abnormalities, only a pericardial effusion, and sometimes we don't see anything. So the key message here is you have to have the suspicion if you have typical finding, as in the case that Anna presented, but echocardiography is sometimes not able to really make the diagnosis itself. But in an acute setting, it's very, very valuable, especially if you want to differentiate between an acute myocardial infarction and myocarditis.
But we are not done yet with this chapter on infection of the heart. We have another case for you. Here is a 40-year-old male who presents with infection, dyspnea, and peripheral edema. It takes long until he comes to the hospital, and this is how his heart looks like. Look lateral to the left ventricle. You can see an echo-free space with little strands inside. Well, I know we haven't covered this topic yet. This is pericardial effusion. This will come later. For now, this is an echo-free space with strands inside. And this is a great example of fibrinous pericarditis. So when you have pericardial effusion together with fever and clinical signs, the suspicion of pericarditis is really high. And you know what this is? Well, this is another case of fibrinous pericarditis, but here the pericardial effusion somehow organized and is evolving into a pattern or constriction. The following chapter will deal with pericardial and pleural effusion. There, we will talk about infection again.